Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil, and I'm very happy and grateful to participating in this great meeting. So I thank my colleagues and friends for the invitation to participate in the Glastemia Ophthalmological International Conference, especially Dr. Jorge Rocha from Brazil, who invited me to participate in this meeting along with friends, with Dr. Paulo Vinciguerra and Ricardo Vinciguerra. So I'm honored to participate in this talk with talking about advances in diagnosis for keratoconus and ectatic diseases. We talk about corneal tomography, biomechanics, molecular biology. These are my disclosures, including, of course, Oculus. And I also have a master class, which is an online course that will be translated soon to English with more than 20 hours of presentations related to multimodal imaging of the refractive surgery. So when you think about refractive surgery and keratoconus, there is a very interesting coincidence on the number of publications related to keratoconus with the emergence of refractive technologies. We created some paradoxes actually with some paradigm shifts related to the management and diagnosis of keratoconus and ectatic corneal diseases. And it's important that we are keen on the understanding of the hows and the whys of applying the technologies for diagnosis and treatment. Refractive surgery can cause ectasia, can cause progressive iatrogenic ectasia, not only with LASIK, but the first reports of LASIK were from 1998, relatively late, considering Professor Burato and Professor Palikari's early work in the early 90s for LASIK with first-generation keratomes. But the first description in the literature are from Styler on cases that had LASIK for high myopia, which caused the compensation of the biomechanics of the cornea. Also, a few months later, in 1998, he published also the Forme Fruste keratoconus defined as Forme Fruste based on front surface topography as a cause of iatrogenic ectasia. Those two reports allude perfectly to the pathophysiology of ectasia, which is a biomechanical decompensation of the cornea related to the corneal resistance, so that any cornea may undergo this cycle of decompensation that was nicely described by Professor Roberts and Professor Dupes. And the corneal resistance will be also integrated with the impact from the environment. And of course, laser vision correction weaken the cornea, but eye rubbing is the major cause, or eye trauma is a major cause of ectasia, and any cornea may progress to ectasia. So if you want to avoid ectasia, start by telling patients not to rub the eye, not to sleep over the eye, not to scratch the eye, because it can aggravate keratoconus and eventually cause ectasia, which is a major concept on the keratoconus awareness campaign that we had on the Violet June. Ectasia is a very important subject in the literature and huge relevance for us, and very nice work by our editor-in-chief of the JRS, Dr. Brad Landeman, that we have corneal topography in the top of the list for the risk factors. And of course, corneal topography may be considered a possible surrogate of corneal biomechanics, but I would say the concept of considering Forme Fruste keratoconus to be abnormal topography may be misleading, but this is interesting that we can integrate topography with other factors, residual stromal bed, the pre-op thickness, and the level of correction. But a very big contribution, I would say, is the inclusion of age. Thereby is not specific because you can have a young patient with a strong cornea and also an older patient with a weak cornea. Age is a surrogate of corneal biomechanics. But the major concept is, what is Forme Fruste keratoconus? Forme Fruste keratoconus defined by Yaro Rabinovitz as abnormal topography when you have 20/20 and normal slit lamp. So 20/20 distance corrected and normal topography, and this is a right eye of this patient, will be a Forme Fruste based on Yaro Rabinovitz concept. A very nice editorial by Professor Kleiss, Steve Kleiss, in 2009. He described that Forme Fruste keratoconus can be the fellow eye of patients with keratoconus, fellow normal topography eye with a patient with a mild ectasia in the other eye. I call those cases very asymmetric ectasia. We have the consensus that ectasia can occur in any eye and it can be unilateral, but keratoconus is a bilateral disease. So it's important that we understand this difference and eventually consider the nomenclature so that we can have future papers with a better understanding of this conundrum. So Forme Fruste keratoconus is still no consensus about it. I like the concept of mild disease. It's a mild subclinical subsymptomatic disease that can progress or not for the full-blown diseases. An incomplete aborted disease, the form fruste, and the full-blown will be the clinical disease or the form plain of keratoconus. And my contribution is that the form fruste is a cornea with a high susceptibility for ectasia progression. So we have cases like this one. This patient had a thin flap LASIK, a subbowman keratocondylosis LASIK in 2008. Residual stromal bed was 304, very acceptable, more than the 250 limit that the FDA still requires, and the PTA was lower than 0.4. Interestingly, there's a little yellow here on the IS, on the not a inferior steepening, but a little yellow on the curvature map based on the scale of Steve Kleiss, Mike Smolik, the 1.5 absolute scale. But this case was part of a study that looked at the subjective variability of classifications of experts, and the mode was 0 with this scale and also with a 0.5 normative scale. Interestingly, corneal tomography was obtained from this patient, and retrospectively, we could go look back at the raw data and see ectasia susceptibility based on a low Artmax, then lower than 400, and a bad D that was higher than 1.5. So this is a patient that we were able to detect ectasia susceptibility, but looking at a larger population beyond anecdotal cases, we have in 10 years been able to collect 105 cases that we have the pre-op pentacam data and look in a comparison study for the pre-op of stable LASIK, 3,278 cases. The classic IS value could be the absolute value, so it could be superior steepening or inferior steepening is very specific, 98% of specificity. So only 2% of the surgeons, of the cases were operated because the surgeons tend to obey the inferior steepening or even superior steepening, but the sensitivity is very low. So we need definitely to go beyond the surface. The bad D was not considered when these patients were operated because it was not yet on the software, and the bad D will be detecting 59% of cases higher than 1.5. Interestingly, artificial intelligence can do better. The Pentacam Random Forest, very nice work, a brilliant work by Bernardo Lopes, who I had the privilege to collaborate in his PhD thesis, and demonstrated to improve with artificial intelligence. The Brazilian Artificial Intelligence Network started pretty much in this time, actually 10 years ago, and this was published on the AJO, the Enhanced Tomography Assessment based on artificial intelligence. So it's important that we understand that even though we improved, we have cases down here, and those cases down here demonstrate the need for more data. And more data, I would say, we have a few directions. We have segmental tomography with epithelial thickness. We have biomechanics. We have molecular biology and genetics, for example. So OCT is what we are talking about today, but it was first described by Professor Reinstein with the very high frequency ultrasound, the digital very high frequency ultrasound, pioneer work in the 90s, when he was able to detect the epithelial thickness on the segmentation of high frequency ultrasound based on the signal of the echoes from the high frequency ultrasound. So in his idea, the epithelial thinning will be an attempt to mask the protrusion. So if you have thinning coincidence to the stiffened area, it will be an indicative of keratoconus. So it's an important thing that we were able to start doing that and having these observations when we have the popularity with spectral domain OCT. So Professor David Huang in his lab, in the Cool Lab, with colleagues like Professor Yang Li, they were able to demonstrate the segmentation of the epithelium from the total corneal thickness, and even demonstrate the pattern standard deviation, which is a very interesting index. However, it's not still approved and it's not allowed in the software. But we have cases, for example, like this one. This patient has a anterior basal membrane dystrophy, and you see how easy it is to remove the epithelium. And this is a steepened cornea on front surface topography, the placido disc topography, the topometric, even the D is a little abnormal, but this patient does not have ectasia. You see a very thick epithelium, which is related to the anterior basal membrane dystrophy. So it's interesting that we can enhance either the sensitivity and eventually the specificity, but we need to have objective data for analysis. So there is a true revolution in evolution on OCTs for cornea analysis. Some multimodal imaging tests like the Revo and the Cirrus that can have, along with the cornea analysis, macula and optic nerve. The Revo is even able to do axial length measurements. We have the MS39, very interesting machine that has also the Placido. We have, of course, the Anterion that has a strap source with axial length measurements that you're able to do the segmentation and have the score analyzer. We have the Cassette 2, very nice OCT, cornea and anterior segment OCT for analysis of the cornea and anterior chamber from Tomé. So we are looking at a true revolution of OCT technologies. And the ability to look at the epithelium is not only with the OCT. We have, for example, the Preciso from Italy, a very interesting machine that has Steinflug, digital laser Steinflug that can get you epithelial measurements. And I must say that the Pentacam, who have a higher resolution Steinflug camera and also an OCT that will be integrated to the family of my technologies that we have. So it's a true revolution in evolution, and we are keen to see the advances and the ability to integrate this data for clinical analysis and the best decisions for helping our patients. Not only the OCT, but the elevation and curvature of the Bowman's layer. Nice work by Raj Shetty's group in Bangalore, India, with Abhijit Tintaroy and colleagues, that were able to demonstrate the ability to segment the curvature and elevation from the epithelial stromal interface. So it can be also integrated. Julie Schallhorn demonstrated the ability to differentiate keratoconus and warpage. You have a thick epithelium coincident to the area of steepening. This will be more likely to be warpage. And you have a thinning, you'll be considered as keratoconus. And this will be an agreement with the rules of epithelial healing by Dan Reinstein. The epithelium has the ability to alter its thickness, and it can be induced by contact lens, by the abnormality of the cornea, and this would be able to regularize the cornea. So when we have irregular astigmatism or high order aberrations, because the epithelium reached the maximum limit for its regularization. Nice work in terms of Marcella Salomon's thesis. You can see the coincidence of the thinning of the epithelium with the elevation and the curvature, and in more advanced keratoconus, and you have even a thickening here that coincides to the area that you have depletion of stroma in advanced keratoconus. In the fellow eye, you have a little bit of thinning, which is something that I definitely would love to develop a way of analyzing it with artificial intelligence. But not only for the diagnosis of the pre-op, but the post-op. This patient was analyzed by Professor Reinstein in London Vision Clinic, and this patient had a thickening of the epithelium, nicely seen on the OCT. It's a true non-contact, non-touch biopsy. It's an optical biopsy of the cornea. You see the corneal ring segment, and a few months later, after the procedure, the patient's getting better, and this is epithelial modulation, thinning and thickening. The fellow eye of this patient, the left eye of this patient, was considered to have unilateral ectasia. The patient had 20/20 plus. This is the aberrometry of the eye trace, and this patient, this is the ring segment implanted with a very nice result. And this patient was followed in London Vision Clinic, and the ability to see the normal epithelium along with normal anterior, the Orbiscan score was very much consistent with the unilateral ectasia. So unilateral ectasia can exist. I would say any cornea may develop ectasia, but keratoconus is a bilateral disease. So it's important that we distinguish that. And this patient was retrospectively analyzed by the software that we developed a few years later. So 2014, we had the data from the Corvis and Pentacam. So the TBI was 0. And in a follow-up, a more recent follow-up, he was still very stable in the left eye. So it's a true unilateral stable ectasia with no disease in the fellow eye. Interestingly, corneal biomechanics is possibly analyzed by the Corvis today. We have objective data derived from the 140 frames in 31 milliseconds from the Corvis ultra high-speed Steinflug camera, and nice work by my colleagues, Professor Paulo Vinciguerra and Ricardo Vinciguerra, that we have the CBI, the detection of keratoconus with a biomechanical index based on artificial intelligence, a linear regression analysis, so that you can see if the cornea is softer or stiffer. And this is combined with the tomography and the work that we do for integrating the Steinflug imaging, including the patients with a normal topography based on a strict criteria at 94 cases. We have an optimized cutoff value, and we have recently describe a second generation of the TBI for enhancing the sensitivity and specificity based on artificial intelligence. So this is truly an evolution into the concept of understanding ectasia susceptibility. So I believe this is important to consider when we think about refractive surgery, if the patient is a good candidate for LASIK, SMILE, or surface ablation, or eventually only for phakic IOL, considering the relational tissue alter, which is a concept that we are introducing with the brain, considering the impact of the cornea from the surface ablation for flap and cap plus the tissue removal. Or eventually, if the patient has a follow-up, need to, as a therapeutic patient, and not only to improve the efficiency of surgery, but also sensitivity to detect the susceptibility, first do no harm should be considered. We have cases like this one that has 2015 relatively suspicious tomography. The bad D will be 1.35. It's still not even in the very yellow range. It's pretty much in the borderline, but the TBI would definitely demonstrate that. And the fellow eye of this patient has mild keratoconus. Actually, it could be considered subclinical keratoconus because her distance correct vision was 20/25 plus. So interestingly, you have the sensitivity to detect the differentiation. We have the evidence of corneal ectasia as in the three daughters of a patient with keratoconus, nicely described by Dr. Shizuka Ko from Japan. And so all the three daughters, all the eyes had 20/20 or better distance correct vision, and we have many abnormalities detected on tomography and biomechanics. Another situation, very interesting, on identical twins. The first twin sister had asymmetric ectasia that was demonstrated to be asymmetric keratoconus with a Forme Fruste keratoconus in the fellow eye, and the fellow twin with both eyes very normal on topography. She had a TBI of normal in both eyes. So it's a very interesting situation. And this patient was analyzed by genetics with the Avellino test that we had abnormality detected at this level as well with the ectasia susceptibility. So when we think about genetic tests, we have a potential to a new revolution in diagnosis. It can be really integrated to the imaging for the cornea. And we have the genes that are related to the corneal stroma, the collagen, and the substantia propria of the stroma, but also to inflammation. And we have to understand ectasia susceptibility definitely beyond imaging into this molecular biology domain. This has been very nicely promoted and studied by the Roger Chetty's group in attention, for example, of lysyl oxidase, which is a very important factor for the deregularization of collagen level at the collagen level. So he had a very nice study on a patient that had its ectasia after SMILE, and he had the lenticle stored in under the frozen lenticle, and he was able to consider the analysis of this lenticle LOX. So considering in a comparison study with some other lenticles from patients that had stable SMILE, considering the LOX as a factor for understanding the susceptibility of the cornea. Also, inflammatory factors like MMP9 and keratoconus can be related. We don't know if it's a cause of a consequence, but we are definitely on the horizon to see molecular biology and genetics to integrate with the understanding of ectasia. I will finalize with a very quick case presentation. A little kid of 6 years old presented for a second opinion. Colleague would indicate in the left eye DALK, a transplant, a lamellar transplant in the right eye caused linking. She had 20/25 distance correct vision, uncorrected 20/30 in the right eye, and 6 years old with 2200 and a super p-hole of 2200, so a huge risk for amblyopia. The first thing is to look at the data on the right eye. She had Forme Fruste keratoconus based on the thinning of the epithelium, abnormal D, integrated shine fluid tomography and biomechanics with a TBI that is even more abnormal in the TBI V2. But the fellow eye, so there's a Forme Fruste keratoconus, but the fellow eye, the abnormal eye, we have keratoconus, and this patient needs surgery because of the risk of amblyopia. She needs to have very important to have addressing, and you see the thinning of the epithelium. And a colleague would say DALK will be the first thing to do in the left eye, but I would say that's the least thing to do My management was first starting with patient education, treat the allergy, optimize ocular surface, and advise not to rub the eye. No surgery in the right eye for now, and a therapeutic approach that will be definitely staged with more than one procedure, and also including occlusion therapy because of amblyopia. It's important to stress the need for no rub, no rub, no cone. We talk about the Myanga canal. It's not only that, but it's a very important message that we have to promote. So the first procedure was epi-on cross-linking with corneal ring implantation. So we do a femtosecond tunnel. We implant the Kera ring and also use the riboflavin in the tunnel for doing epi-on cross-linking. This patient did very well. She tolerated for about 6 to 7 months the occlusion in the good eye so that she was able to stimulate the left eye. So it's important that she saw some regression and she was not able to tolerate anymore. So we did go for more surgery. We did the modified Athens protocol, which is today called the Tel Aviv protocol, is a topo-guided procedure on the epithelium, and we do some smoothing on PTK with mitomycin C and riboflavin, and followed by a fast cross-linking 9 milliwatts to get the dose of 5.4 joules per centimeter square. This patient did very well, and I really believe there was more than lucky on this case, but she did very well, and she's still stable up to the last follow-up that we had last year. She's now 2015, this is correcting the right eye, and she's 2025. Of course, I'm worried a little bit about some flattening that we can have on the left eye, but definitely she is free from amblyopia in that eye. So you see the topometric maps on the treated eye. We see the epithelial thinning that was getting better and better. And after the second surgery, we got a regularized cornea. And the fellow eye, the right eye, she's stable. She's stable topometrically, tomographically, biomechanically, and of course, front surface topography is very stable. So the no surgery with, even she had oral riboflavin as part of her treatment when we first learned about that, from Professor Justad from Minnesota. Now he is in Florida, and this is a very important thing to do. So I think doing cross-linking in this eye would definitely increase the risk for losing this is correct vision, and the history demonstrated in this case that we definitely had the right decision. So when you think about advanced diagnosis for ectasia, the what's, the why, the how's, we have to understand enhanced screening for ectasia risk is different than managing patients prior to keratoplasty, considering the paradigm shift. We have objective versus subjective data. We have to apply artificial intelligence with philosophy, and this is the algorithm that we described, A2I squared. We have characterized ectasia susceptibility. We have staging, prognosing, classifying, follow-up, and definitely clinical decision, this true revolution in evolution using multimodal imaging with a proper approach, understanding what we're trying to achieve and using the technologies with the best strategy as possible. So thank you very much for your kind attention, and I really look forward to the discussion and for collaborating with all of you soon. Thank you.